Hello, everyone. Welcome to this seminar of the Australian and New Zealand Stroke Organization. So we have two speakers today, and they will talk about the World Stroke Organization Rehabilitation Unit Certification, which is a collaboration between the WSO and ISRRA. And our two speakers are Associate Professor Liz Lynch. She is a physiotherapist and a research fellow at Flinders University in South Australia. And Liz works closely with people with lived experience of stroke and health professionals on projects to improve how stroke rehabilitation and life after stroke services are delivered. Liz is a co-chair of the Australian New Zealand Clinical Guidelines Working Group and a member of the World Stroke Organization Guidelines Committee. And then we also have Dr. Jessica Nolan. She's an early career researcher and a physiotherapist too. She works as a teaching and research academic at Curtin University in WA. And Jess is a current member of the World Stroke Organization Future Leaders Program and the WSO Rehabilitation Implementation Committee. She's also a member of the ENSO Early Career Committee, and she is a member of the Stroke Foundation Living Guidelines Working Group and ISRRA Early Career Group, lots of committees. And she, as a clinician, just saw disparities in access to rehabilitation and is now focusing on working with communities to make stroke rehabilitation more equitable. So let's start off this seminar.
Thanks, Sharon, very much. I'll start us off. So before I start, I want to acknowledge that I'm presenting from Wadjuk Noongar country in Perth, and Liz is on Kaurna country, and Sharon's over in the Netherlands. But so I acknowledge the traditional owners of the places from where everyone across Australia is joining, and pay respect to traditional owners past and present. I also extend that respect to any First Nations people who are here today. So the recognition of the importance of access to rehabilitation is gaining momentum. The World Health Organization Rehabilitation 2030 initiative was announced in 2017, calling for action to advance rehabilitation globally. The World Stroke Organization Lancet Neurology Commission also identified rehabilitation as one of four key priorities to reduce the global burden of stroke. The World Stroke Organization Rehabilitation Implementation Committee was convened in 2022 to promote access to evidence-based stroke rehabilitation. So the World Stroke Organization launched an acute certification program, which started in 2022. The aim was to promote evidence-based care. Similar to the success that we've seen with the 30-60-90 target program for acute stroke care in Australia, the World Stroke Organization Acute Certification Program has been shown to be an effective way of measuring and ensuring evidence-based care. More than 100 hospitals globally, particularly in low and middle income countries, now have World Stroke Organization acute certification. So the World Stroke Organization Rehabilitation Implementation Committee then formed, considering the global need to advance rehabilitation. It aimed to develop evidence-based, internationally relevant recommendations and performance indicators for stroke rehabilitation. So I'm going to hand over to Liz now, who will talk through their development.
Thank you, Jess. So this piece of work has been going on for quite a while. Started by others, and Jess and I kind of joined to probably a year or so ago, or 2 years ago probably actually. So the World Stroke Organization have many committees, and one committee was tasked with synthesizing the global guidelines. So that started in 2021. It was coordinated by Gillian Mead, who works with Cochrane, and was published in 2023 in the International Journal of Stroke. Following this, the World Stroke Organization Executive Committee formed a rehabilitation committee to support implementation. And so the idea was that this committee was going to bring together international health professionals and researchers with experience in neurorehabilitation, stroke neurology, and implementation science. So then this group then looked at the World Stroke Organisation guidelines, looked to see whether or not they were ready to be kind of implemented internationally. So they initially reviewed that and made some suggested adaptations, like rewording and adding some recommendations as well, so that this would support implementation of the recommendations in different international contexts. Thanks, Jess. And so this is just a visual showing where the different Rehabilitation Implementation Committee members were from. There was good representation in high-income countries as well as low-middle-income countries. And most of them were either medical or allied health professionals. I don't think nursing is very well represented at all on the committee. Mary-Louise Bird was the first Australian on the committee. Thank you. So in 2025, 3 groups were semi-invited and semi-asked whether or not they were able to consult on these recommendations, because what I forgot to say was that some pilot testing of those recommendations had started. So then some people said, "Oh, can we have a look at those criteria, please? Can we see whether or not we've got any? Can we have a look and review them?" And we're told yes. So one group was a group of people with expertise in stroke guidelines. And so we had people who'd worked on the Australian New Zealand guidelines, people that worked on the European guidelines, Indian, Singaporean, and the UK Irish guidelines to review the recommendations, and looked at strong recommendations using the Australian and New Zealand stroke guidelines as the core group of guidelines, and then compared them across with the other guidelines from the different areas to identify which recommendations were consistent across the different international guideline groups. At the same time, or perhaps a little, no, back please, there was a group from the World Stroke Organisation Future Leaders, Cohort 3. So Jess Nolan and Laura Jolliffe are involved in this work, along with some others from different countries. So the CareMap project team, where 50% of people were from middle-income countries, mapped rehabilitation recommendations from 3 systematic reviews and syntheses of global guidelines against the Australian New Zealand guidelines. And again, the Australian New Zealand guidelines were selected because they're the living guidelines using grade. And when this group had methodology where strong recommendations from Australia and New Zealand were included in one or more syntheses, they were included in their final set of recommendations. So these 3 groups were working separate from one another at this point in time. Then there was a third group of people who'd been involved with the International Stroke Rehab and Recovery Alliance, Centres of Clinical Excellence work, and they looked at, so then a group of people who'd been involved in developing or pilot testing the ISRRA Centres of Clinical Excellence criteria, reviewed those criteria for application in the World Stroke Organisation process. Criteria that were not already covered by recommendations from the World Stroke Guidelines Review or the Australian New Zealand guidelines were nominated for inclusion and reworded to align with the other recommendations. Thank you, Jess. So I presume not many people know what the ISRRA stuff is about, so I'll just do a whistle-stop tour about that. This was some work started in 2019, I think, 2018, and coordinated by Marianne Walker from the UK. So this group of work was designed to define globally relevant criteria for centres that aspire to deliver excellent clinical rehabilitation and generate exceptional outcomes for patients. So this was one of the core work pillars when ISRRA was first set up. One of the things that they thought, if we can really identify what these excellent sites are doing and what makes them excellent, that can help us advance the field of rehabilitation. So the first thing we did was to do a literature review, but there was no single definition of what a centre of excellence is, but there was a common theme that generally there were really highly skilled people working there. They were generally involved in research and innovations in ways that advanced the field of whatever field of excellence they were working in. And quite commonly, there was guidelines and standards specific to their endeavours. So then Marion coordinated a work group. And again, it was an international work group trying to get global representation. Brought this group together. We did the literature review. We had online discussions, discussed what makes the centre excellent, lots of discussions. We got feedback from people who lived experience from different parts of the world. And then crafted up some criteria and then did some ranking of those criteria where both the people in the expert working group as well as panels of people who lived experience from Australia, UK, India, Malaysia and the US ranked those criteria in order of what was most important. Thank you. And then in 2022, Thoshin Kandasamy did her PhD looking at testing those criteria to see whether or not they were relevant, whether there was data could be collected, whether people knew what the criteria meant. And she did that in 10 countries, at 16 sites in 10 countries. 2 were Australian sites, 1 was a metro site and 1 was a regional site. And across the world, everybody said, so those are the criteria there in order of priority. So delivering excellent rehabilitation and optimal outcome was deemed the most important criterion of a centre of clinical excellence in stroke rehab. Everybody said, yes, that's relevant. Having a research culture was deemed relevant, even in low middle income countries, which we weren't sure whether or not that would apply there. Having the theme where you're working together, the team works together, the patients and families work with the team was relevant. The least important criterion, it was still deemed important, but least out of the 7 was advocacy. So that is that centres of clinical excellence in stroke rehabilitation advocate and promote equitable access and optimal delivery of stroke rehabilitation services wasn't deemed relevant at all, those sites that participated. It certainly was at some, but not, that wasn't consistently accepted as part of core business of being a really good rehab centre, advocating for equitable access and optimal delivery. So everything else, we kind of passed the pub test really with these criteria that experts came up with them, people lived experience validated that, and then Thoshin took it out to sites external to the generation process and they said, yes, these work too. So that's the ISRRA criteria. So then how we brought those 3 work streams came together. So we had the guidelines group, we had the care map group, we had the ISRRA group, and came together to figure out how do we make sense of these 3 pieces of work. And so we decided that recommendations would be included kind of in the core set of what we thought would be important if it was a strong recommendation in 2 or more guidelines, or if it was if there was a recommendation that was high certainty evidence that might have only been in 1 guideline, but we anticipated it to be relevant for more than 50% of stroke survivors and it's associated with meaningful benefit. This bit about practice to avoid came up from working with the people from low middle income countries, where things that were commonly practiced, but where the risk of harm outweighs the risk of benefit, we added them in. So that was things like using overhead pulleys for shoulders and using amphetamines to help with alertness. Apparently both those things are quite common in Brazil and India. So it's important to avoid them because they are associated with not great outcomes. And then the criteria from ISRRA Centres of Clinical Excellence that hadn't been included already were added into the mix. And then a presentation was given to the World Stroke Organisation Rehabilitation Implementation Committee. So at that point, we put together a presentation. So the leads of those 3 work groups put together a presentation to the rehab committee. They really liked the process that we'd gone through. They appreciated the transparency of it, and the people who led the different work groups were invited to join the implementation committee. So that was when Jess and myself and Kwali Kim from Singapore was also invited to join. And So then at that point, the pilot testing of the criteria continued, but now using these refined recommendations. And we developed an implementation manual to support the assessment process and to support clinicians. We came up with what we thought would be good as mandatory recommendations and different recommendations for different service levels. And Jess will go into that in more detail.
Thanks, Liz. So we piloted these criteria, this program, in a total of 15 centres from 6 low and middle income countries. So the pilots took place from November 2024 to September 2025. 8 different assessors did the pilots, representing 5 countries themselves from the assessors. And some of the assessors were from high income countries, some were from low and middle income countries. So I was very fortunate to do a pilot assessment at An Binh Hospital in Vietnam. I learned a heap by getting to do this. So you can see that the car park at the An Binh Hospital looks quite different to an Australian hospital car park. The team there was amazing and welcomed me and were very eager to participate and learn more about this program. Some things that I really was struck by doing this pilot in Vietnam was, first of all, how this team was really, truly showing interdisciplinary care. So both occupational therapy and speech pathology are new professions in Vietnam. I believe that there are less than 200 occupational therapists in the whole country, and speech pathology is also still quite rare. So the team that I was working with at An Binh Hospital, actually all of the occupational therapists and speech pathologists had retrained as, so they were physios that had retrained as occupational therapists and speech pathologists. So I thought that was amazing dedication to go back and retrain to a new profession to fill a need in their country. Rehab, the model of rehab was quite different to what we see in Australia. So at An Binh Hospital, patients tended to be discharged from inpatient care quite a lot earlier than they are here. And families do the care in the hospital, but then they also quite quickly look after the person who's had a stroke at home. And then the stroke survivor comes in for rehab very early on, but they can come in every day and spend all day and see every profession every day during rehabilitation. So the amount of rehab that they were delivering was really quite high. And the integration of the family and carers into rehabilitation was also something that I think, they do really well there. Families are always integrated in rehab and expected to be part of rehab. So it's a really interesting thing to see how rehabilitation is being delivered and how quite good rehabilitation is being delivered in a low resource setting and in quite a different model than what I'm used to in Australia. So after we finished all of the pilots, we came up with 3 levels of certification that are in line with the WSO acute certification program. So the 3 levels are based on resource availability to make this globally applicable. So minimal level of certification would be a low resource setting or possibly a setting that's just starting out. So typically we learned that these settings tend to have access to a medical doctor, nursing, and physio. So then based on what we learned from the pilots and people's committee members from low and middle income countries, we developed recommendations that would be suitable with those resources available in a minimal setting. Then an essential service would be more of they're providing evidence-based care. So really quite competent rehabilitation delivery based on evidence. And then an advanced setting or an advanced service would be a high resource setting. And they're, of course, delivering good evidence-based rehabilitation, plus they're contributing more broadly to rehabilitation. So we'll talk about that more, but they're doing things like engaging with research and the ISRRA criteria that Liz has already described. So the criteria are still under review by the World Stroke Organization Executive Committee. So the next parts that I'm going to present are still, they could still change a little bit. They're right now under review, but this is what we've got so far. So we've divided the criteria into mandatory and recommended. I'll explain our decision making on the next slide, but mandatory criteria must be met in order to be certified. But of course, we still recommend that sites are delivering the recommended criteria. We've outlined the requirements for minimal, essential, and advanced services. We've come up with a total of 55 recommendations. Of course, not all 55 are relevant to each level of service, but 9 of the recommendations are service level, 46 are patient level. So mandatory criteria are set for both patient level and service level recommendations. So at patient level, the mandatory criteria came from strong recommendations from at least 2 high-quality guidelines, and they were also supported by high certainty evidence. Strong recommendations that were supported by moderate or low certainty evidence were recommended. So to be clear, we still want sites to deliver the recommended criteria too, but they need to deliver the mandatory criteria in order to be certified. And then the service level mandatory criteria came from the World Stroke Organization guideline synthesis and consensus from committee members. So the mandatory recommendations were things that enabled us to do the audit. So for example, everyone needs to have a documentation system to enable us to audit the care that is being delivered. Staffing requirements that would be required to meet that defined level of service. And then also for advanced certification, 4 recommendations from the ISRRA sensory or Centers of Clinical Excellence were mandatory for advanced centers. So the only committee members who are not involved in developing the ISRRA criteria voted on the criteria to be included in the advanced certification, just to make sure that there were no issues with conflict of interest. So there was consensus among the rehab implementation committee members who weren't involved in ISRRA that these should be included in our advanced recommendations or advanced mandatory criteria. So this is the proposed scoring guide, which is again still under review. It was informed by the World Stroke Organization acute certification program scoring. So at first certification, minimal and essential sites should fully meet all mandatory criteria that are set for that level, plus 75% of the recommended criteria. And advanced sites must meet all mandatory and 85% of the recommended criteria for that level. And then we propose certification 1 year after the initial certification, then every 2 years. So at second certification, we'd expect minimal and essential sites to still meet all mandatory criteria, plus 85% now of recommended criteria. And we'd expect advanced sites to continue to show ongoing improvement. So we're hoping that, we are expecting that sites, even when certified, are still continuing to improve. So there are different criteria relevant for each level. So 31 criteria in total are relevant for minimal certification, 51 for essential, and all 55 are relevant for advanced certification. We've also developed an implementation manual, which is also being reviewed now by the World Stroke Organization executive. So this provides additional information to guide both clinical application by the sites, as well as assessment by auditors for certification. So the implementation manual addresses who, what, and how for each indicator. So it gives a bigger definition of what we actually mean by the recommendation. So the what gives stronger definitions, and then how it should look. And then also we've discussed who should deliver this recommendation and who should receive it. And then added on a performance indicator that will facilitate consistent assessment among auditors. So the recommendations are underpinned by the principle that stroke survivors are deemed suitable for rehabilitation when they're medically stable, they're not receiving end-of-life care, and they have functional goals. Geographic location of a stroke survivor's home, community, and financial means should not affect access to or quality of stroke rehabilitation. We also acknowledge that stroke care is recommended as the gold standard, but this program aims to promote evidence-based practice everywhere that delivers stroke rehabilitation. And I'm going to now hand over to Liz again to go through the recommendations.
Thanks, Jess. So this slide is some of the service level recommendations. So most of these are mandatory for advanced centres. So it was interesting, I think, part of the things that I found interesting is that a group of us, which were probably mostly, in fact, the four of us that ended up doing the first draft of what's advanced and what's essential, what's mandatory for advanced and essential for the service level recommendations. We had representation, it was just myself, a woman from the States and a woman from Singapore did the first try at this. And we didn't have very many things that were mandatory for essential level services. So that would be typically for good centres in low middle income countries. And there was a lot of pushback from the people who actually worked there and said, no, in our country, that should be mandatory. So things like having a data collection system to monitor performance metrics. We didn't recognise that the infrastructure is there in low middle income countries and should be being, from the people that live there said that's what we want, that's what we need for our country, that should be mandatory. So things that are mandatory is that you should, for advanced centres, is that you should be engaging in quality improvement in stroke rehabilitation. You should be doing research. So advanced centres will be research active centres. We know that research activity in hospitals equates to better patient outcomes, and so as well as quite a lot of service indicators, performance indicators. Another mandatory thing is that there should be a degree of education, so education and outreach about what stroke is and advocacy. Doing the mentoring, and we see this a lot in high-income countries. The States does, some of the big centres in the States do this a lot, where they do some outreach to places in different countries, in low middle income countries. And like in Australia, we see this a lot in terms of the metro sites often doing outreach and support to regional sites. So that's the sort of stuff we're talking about with mentorship, is that support external to your actual base hospital. Everywhere, whether you're a minimal, essential or advanced, must be involved in professional development. So we are looking for staff to be trained in what stroke rehabilitation is. And then the recommended hours do alter between the levels of service. So as Jess said, we had to have a mandatory criterion about documentation, and that came out of some of the pilot testing in India and maybe Brazil, I'm not sure, but where the documentation just was not consistent at all, and you cannot audit your practice if you're not documenting. So that is a mandatory criterion to achieve minimal certification. Thanks, Jess. So then these are all patient level recommendations. So there are many, so we won't spend too long on them, but they are clumped generally into, grouped into how rehabilitation is organised and started. So when it should start, how often you should get it. Thanks, Jess. We have things around swallowing difficulties and hydration and nutrition. Information provision and goal setting, exercise and motor rehabilitation. So there's quite a lot more in this sort of space, and it is that. So the only patient level recommendation that is mandatory, and it's the nature of the evidence we have in stroke rehabilitation, is about walking practice. So we know we have strong recommendations based in very solid evidence that people who have trouble walking, when they practice walking, their walking gets better. So the other things that are not mandated, it's because there is not consistent, strong, high quality evidence underpinning the recommendation. We've had quite a lot of discussion about the timing of rehabilitation, like getting out of bed and the timing of that, because a lot of people wanted that to be mandatory. But because I think everybody that works in rehabilitation, we really want to mandate you must get out of bed after you've had a stroke. That's part and parcel of core rehabilitation. If you're not doing that, then you're not providing rehab. But because we actually don't know the safety parameters of when and how often to do that, at this stage, it's still under review. At this stage, that's not mandated because the parameters of how to do that safely are very likely to change as more evidence becomes available. So that is recommended now, but not mandated. So the only mandatory one is about walking practice. Visual function, so visual screening and referral as needed. And a lot of these ones are good practice points, so that we don't have randomized controlled trial evidence about what happens when you don't give a screening, visual screening and those sorts of things. The quality of the evidence and underpinning evidence and the grade certification mean these are things that are recommended rather than mandated. At this point, there, hasn't been signed off yet. So mood and cognition, again, recommended that people are screened and referred on if there's any issues identified. And so also covering prevention and management of complications. So you can just see it's a very, very comprehensive, or we think it is, a comprehensive look at what should be happening in the rehab stay. Quite a lot more there. And so I think there are quite a few. So we have things like shoulder strapping should not be routinely used. Overhead pulleys should not be used. Splinting and stretching should not routinely be used for the sorts of things to avoid, which are apparently quite commonly used. And then discharge planning and support. So I think this is me still. So when we agreed to do this webinar, we're of the understanding this would be after it has been reviewed by the World Stroke Executive Committee, but that has been delayed somewhat. So that is going to be reviewed in the next 2 weeks. They've certainly reviewed it and we've had some feedback, but it's not got approved that this is good to go yet. So this is the work in progress, is the work that's been done to date. There may well be changes to it. And the understanding is the certification program will be launched this year. Our working group is, we've been very busy getting it to this point, and the next steps that we need to do is to figure out the plan of updating these, so as new evidence becomes available, having a system and a process to incorporate that into this certification plan. We have not done much work at all to date on incorporating the perspectives of people who've survived a stroke themselves or people that support them. And so I do think that is some work that we will be wanting to address. But, and I think lots of us that work in rehab, it is the state of play that we're still really keen to get more and more high quality research evidence so that we can be more consistent and clear about exactly what and how and when and who should that precision rehab, who should be getting what and when. The more we can keep moving the rehab knowledge, the research knowledge along, the better this sort of process will be. So in terms of what does this mean for Australia, there's possibility to align this sort of stuff with initiatives in Australia. But at this point, really what we're doing here in this talk is just sharing this work that's been undertaken for the World Stroke Organisation by the World Stroke Organisation. And we're hoping that some of the work here can enable local discussions about applicability and relevance and governance for a rollout, but that's not the remit of what we're doing here. So I think what is good to go at the moment is to be using this framework in a research context, which Jess can talk to.
Thanks, Liz. So now we're working to apply this project in the context of an implementation research project in Western Australia. supported by the Western Australian Future Research and Innovation Fund. So Western Australia has quite specific challenges in rehabilitation service delivery and access, considering the size of the state and the need to reach remote populations. So we can test the application of this WSO model in Western Australia, considering our unique challenges relating to access. So we think that it fits that metropolitan sites in Perth, Australia being a high-income country, we would expect should be able to meet the advanced criteria. So they should be delivering evidence-based care and contributing more broadly to rehabilitation. We expect that regional sites should be targeting essential certification criteria. So they should be delivering evidence-based rehabilitation. And we also know more remote sites are more likely to be able to strive to meet or able to meet minimal level criteria, which would be delivering safe care with links to higher level, better resource sites to then add to the rehabilitation or the strength of the rehabilitation that they're able to deliver. So this process this pilot project in Western Australia is co-designed. We have people with lived experience of stroke involved in the project, and one of the people involved in the project with lived experience of stroke also comes from regional Western Australia. The processes for the auditing differ between Clear Stroke, which is what we're calling this pilot project in Western Australia. So the processes for piloting and for auditing differ. So for World Stroke Organization, we're auditing five patient files per site. For Clear Stroke, we are auditing 40 files per site, which is more in line with the previous Stroke Foundation audit procedures. So we're just, I was going to say in the middle of a pilot, but we're a little bit beyond the middle of a pilot process now at Osborne Park Hospital in Perth. So it does seem to fit. It seems to be working. It's going quite well. The team there are very eager to be involved. They were very eager to share information and help me understand where to find the information when I did the audits. So in terms of the service level criteria, the OPH team, the Osborne Park Hospital team already know this, but they do meet all of the advanced criteria at a service level. We haven't finished the medical record audits just yet, but what I have noticed for the most part is that when I met with the team, they told me the areas that they thought that they'd be really strong at and the areas where they thought that they wouldn't meet the criteria. And I think they're pretty well right. It seems to be aligning. So I think that model is seeming to fit in Western Australia. So once we finish the pilot at Osborne Park Hospital, we're now working to hopefully expand this implementation research project within Western Australia, working with key interest holders in Western Australia to see how this fits here. And then, so we're at the end, but before I invite questions, I want to acknowledge the team who was involved in developing these criteria. So this was the group from the World Stroke Organization Rehabilitation Implementation Committee, and then a few other key interest holders who joined in along the way and helped out. I also want to acknowledge that I got the opportunity to be involved in this project because of the Future Leaders program. So it's been a really great experience for me to work with the team on this project. So I really want to acknowledge that the Future Leaders program gave me this opportunity. And we'd like to invite questions. I'll stop sharing my screen.
Thank you so much, Jess and Liz. That was a great overview of quite a big body of work that has been done on this. Are there any questions? There aren't any questions, then maybe I'll start off with one. When I was looking at your overview, so you have the service level mandatory pieces and the recommendations, and I could see that on the patient level, there's lots of recommendations. Did you consider, because now all the different pieces are equally recommended, have you considered to put it in as a leveled recommendations like we see in the guidelines? the Australian guidelines, I have to say.
Yeah, I think all of the ones that are in there, the vast majority would be strong recommendations in our guidelines. But in terms of weighting, like we did kind of discuss, did we weight some of these? So for instance, getting out of bed, that was we had so many discussions about that. And does getting out of bed, is that as important as a continence screen or something? I don't know. Essentially, that we would love everybody to get everything. So we, at the moment, I guess that's a limitation really, because for instance, if you did everything and left someone, I don't think you could do everything and leave someone in bed. But to me, clearly I have issues with the getting out of bed one. I think most of these things, most of the recommendations wouldn't happen in isolation. But I think there are probably some that may be more important than others, but I think we just are sucking that up at this point.
I think
and why I ask that question is also because if all the recommendations are equal, and I understand how that it would be hard to weigh it in a certain way, but then if you do your audits, because everything is recommended, and I understand you take a percentage of if they meet those criteria of the recommended ones, they could just do really well in one particular area and not so much in other areas. So it becomes hard to audit, I guess.
I'll let you answer that just because you've done the auditing.
I haven't found that hard to audit, to be honest, Sharon, because we've got the implementation guide. So when I made for ClearStroke, for example, I made the data collection form. And so I could see and go back and say and actually when I was making the form, I found a couple of things in our implementation guide that I said, this isn't actually really clear. So then we quickly talked to the team, revised, sent it up. So we've done that. But I think you're right in that, sites there is a potential that they might do really well in one area and not another. But actually, because we've got the mandatory criteria, and then it's a fairly high percentage that they need to meet, and we're expecting ongoing improvement, it ends up that they are expected to meet most of these criteria. And I think, although, like Liz said, most of the recommendations came from strong recommendations anyway, plus things that people told us were important in low and middle income countries. But something that we left out of the presentation was that we've also developed a document that outlines the certainty of evidence behind each recommendation, and then whether it was a strong recommendation or if it was a good practice point or something else that people from low and middle income countries have told us. So although it's not weighted differently, we have given that information about the certainty of evidence behind each recommendation.
Okay. Laura Jolliffe.
Hi, thanks. Hi, Liz and Jess. Thank you so much for your presentation. I had a quick question about perhaps I'm getting mixed between, Jess, what you're saying with using the results from your clear pilot with the criteria. So I apologize if this is a strange question, and please correct me, but how would you anticipate the Stroke Foundation's rehab audit that currently occurs? Do you think that there's any duplication across these metrics and the data that we collect for the standard Stroke Foundation audits that happen every 2 years?
So thanks, Laura. Good question. My understanding is that the Stroke Foundations aren't going to continue anymore. So there is definitely overlap between what was in the Stroke Foundation audits and what's in the WSO criteria for sure. But it's not, if this does expand in WA, it's not overlapping with the Stroke Foundation audits because I believe that they're not continuing.
Okay, all right, great, thanks.
But I do think there was, I think some of Jess's work was probably informed by stroke audits, like the picking 40 to audit. And I think we're used to doing 40 audits, and so has been fed into this program while she's piloting this, just to see how it fits and how it works here.
Yeah.
If it fits, if it works, probably.
If it fits, yeah.
Any other questions? That's so quiet, people. So, well, I'll kick off then for another question. So with the certification, I think the proposal is that once a site is certified, then there will be another round of audits 1 year after, and then it's going to go on a 2-year cycle. That seems like a lot of work. And I was wondering, is there a plan or a proposal in how that's going to work, and who's gonna take care of the audits in the different countries?
This is a good question, Sharon. We're still working on it. So the yearly audit and then 2 yearly audits is based on the acute process, but that's still to be figured out. How is still up in the air.
Yeah, so I think a lot of the because step one is, like we said, we're a little disappointed that the decision on whether or not these have been passed has been delayed. So this is all under review. We're not sure, So this we're presenting what we've done to date, but it might change before it is in its final iteration. And then from there, we do know the program will be launched within not too far away from getting approval. And from there, the rehab committee needs to determine how we're going to be, because we don't want to certify places and then they're certified forever. There needs to be some sort of quality checking. And a lot of that does need to be noted out. And I think there's, the cost involved needs to be, there's been discussions about it, but nothing's been confirmed. Whether you have people trained within their country that just do within country assessments, or they fly people from further afield, all those sorts of things are discussions we're having that we're not sure about yet. That it's a bit of a moving feast. It's, we think we've landed almost somewhere and then need to recalibrate and then reset.
Yeah. That's what you get working with a large group of people. Okay, there's a question from Jane Wu. Did you consider timely access to rehab? Some wait many days for inpatient rehab and some many weeks for outpatient rehab to start. So is that part of the recommendation?
Good question. So I believe, Jane, that's addressed in the acute certification program. So the WSO has already an acute certification program that talks about timely assessment for rehab, and we deliberately didn't overlap with the acute certification program. So we aimed to have this able to pick up and meet people where they're at. So like, for example, when I've done the audits at Osborne Park Hospital, people tend to come to Osborne Park. I don't know what the average is these days, but it's usually not within that 48-hour window. So that's just not applicable at Osborne Park Hospital. But so I think that kind of answers your question.
I'm just reading Jane's question. It was timely access to rehab. Some wait many days for inpatient rehab and some many weeks for outpatient rehab to start.
Yeah, I see.
So I think in answer to Jane's question, we considered it, but it's not included. That was something that we have it. I definitely appreciate that that's important, but that's something that's not included in in these criteria.
Okay. Am I missing any other questions?
Oh, so Kelvin's happy to take questions. That is correct. The audit has informed, but the National Stroke Audit won't continue in its current form. We're working with rehab community to identify what a replacement or alternative would look like. Kelvin is happy to take questions on that.
Thanks, Kelvin.
Any other questions for Kelvin or for Justin? Okay. Well, if that's it. Well, thank you so much, Jess and Liz, for this great talk. And thanks everyone for attending the seminar. And then that's it for today.
Thanks, Sharon.
Thank you so much.
Thank you. Thanks, Sharon.